is the key to curing breast cancer, and mammograms are the best screening tool that we have. For some other women, we may need to add ultrasound, so this is generally used for women that are under the age of 30 because they have such dense breast tissue on the mammograms that it's very difficult to see. Cysts and fibroadenomas in the breast. If women have very dense breasts, women that have fibrocystic breasts, we use ultrasounds, and also we may use it to, if we feel a lump in the breast, then we may do a mammogram along with an ultrasound to try to identify what that lump is. Ultrasound shouldn't just be for everybody because they're very technician dependent, and so actually things can get missed, so we don't rely on ultrasounds as our main screening tool. And then breast MRIs can be used for very high-risk patients. You know, when MRIs came out, everybody kind of jumped on the bandwagon, and women were showing up at every doctor's office saying, I want an MRI too, I hear it's the best thing, it finds everything, it's better than a mammogram. Well, unfortunately, it finds too much. And women, when we first started doing mammograms, we're ending up getting unnecessary biopsies. Because we were finding every single little thing, we were finding things that were hormone dependent. So, in other words, when a woman would go in and let's say she happened to have fibrocystic disease or she happened to go just before her period, the mammogram, the MRI is designed to pick up the activity of the breast tissue. So they would pick up high amounts of activity in the breast tissue that would cause them to then recommend doing a biopsy or an ultrasound for further testing. So what we found with MRIs is that they're best used for patients that are high risk, patients that are BRCA carriers, patients that have had a history of breast cancer before, patients that it's worth taking that risk of an unnecessary biopsy because they're at such a high risk for developing breast cancer. Women that have lobular carcinoma in situ or atypical lobular hyperplasia, as we talked about before, where they have a marker for breast cancer, which puts them at a 7 times increased risk for developing breast cancer over a lifetime. These patients will likely benefit from MRIs. The reason we like to combine all of these tools for high-risk patients, again, early detection of breast cancer greatly improves the treatment options, the chances of a successful treatment, as well as survival. With breast cancer, to make a definitive diagnosis, oftentimes we need to do a biopsy. So when a woman goes in for a mammogram and we find something, we may recommend doing a biopsy. 80% of the time that a woman is recommended, or 80% of the time that we do biopsies, they end up being benign. Why do we have to do so many? Well, because we need to find those 20% of cancers, and unfortunately, the mammograms and everything, and ultrasounds and MRIs are not perfect. But it's, in some respects, comforting for women to know that when you are recommended for a biopsy, although it's terribly anxiety-producing to be told that you need to have a breast biopsy, 80% of the time they will be benign and not something that we have to address surgically or give any further treatment. Most women who receive an accurate biopsy can now do it as a needle biopsy. So if we find something on the mammogram or the ultrasound, the goal is to always try to do a needle biopsy instead of taking the patient to the operating room to do a biopsy. So it's very important that if you see a surgeon, because you have an abnormal finding on your mammogram or your ultrasound or your MRI, ask them whether, and if they have not recommended a needle biopsy, ask them why they're not recommending that needle biopsy. Sometimes we do have to do surgery and we can't do the needle biopsy, but you want to make sure that's for a good reason. Biopsies can be done as either stereotactic biopsies, meaning that they use the mammogram to guide the needle, ultrasound guided biopsies, so we're using the ultrasound machine to guide the needle in, or MRI. So if you go for a biopsy, what happens if the biopsy is abnormal? Well, we may find that it is benign and has malignant potential, as what we talked about earlier with these atypical hyperplasia cells, or atypical cells. That is something that needs to be removed. A woman may be told that she has non-invasive breast cancer, which is ductal carcinoma in situ. This is non-invasive cancer. It doesn't spread anywhere else. It doesn't go into the lymph nodes. So the cure rate is essentially 100%, but we have to remove it. We have to treat it as a cancer. So if it's done as a lumpectomy, that means removing the cancer and then giving radiation treatment as well. Some women develop this disease very extensively in the breast, in which case we have to do a mastectomy to remove all of the breast tissue if we find it throughout the breast. And then it may also require hormonal, actually endocrine therapy, which is anti-hormonal treatment, which is the tamoxifen that was mentioned earlier. For invasive breast cancer, if they find invasive breast cancer, then obviously that needs to be treated as a cancer. And how do we treat breast cancer? Well, we treat it by a couple of different ways. We can do breast-conserving treatment, which some patients prefer, which means that we're removing the cancer and some normal tissue around it, but we're leaving most of the breast tissue behind. So it's called a lumpectomy. And we are at the same time we need to biopsy the lymph nodes if we found invasive cancer. Then we need to biopsy the lymph nodes using a technique called sentinel lymph node biopsy, which essentially means that we're biopsying the first lymph node that we see under the channel of lymph nodes that's underneath the arm. So we don't always have to take out all the lymph nodes underneath the arm. If we're treating a woman for breast cancer, we just want to biopsy the first group of lymph nodes to find out if there is cancer. If not, we're going to keep the lymph nodes behind so the woman has less chance of developing lymphedema, or else if we have to remove them because we see cancer, we may have to do. That may be a possibility. If a woman has a lumpectomy, then almost always she will need radiation treatment. She may also need chemotherapy or endocrine therapy. Okay. Radiation treatment, very quickly, is given as either external radiation beams, which is about a 6-week treatment course. The risks of radiation treatment are radiation syndrome, which causes fatigue. There may be some skin burning or discoloration, and there may also be some exposure to the lung and to the heart. Nowadays, we can also give radiation treatment by doing partial breast radiation, which means that we insert a catheter, which looks like this, into the breast, and we treat just the lumpectomy bed, which decreases the risk of recurrence in the lumpectomy bed, but preserves the rest of the breast tissue. The nice part about that radiation is that it's 5 days of treatment versus 6 weeks of treatment. You don't get the radiation syndrome, and in addition to that, there's no exposure to the lung and to the heart. The other most important benefit from all of that is that if a woman develops breast cancer again, whether as a recurrence or a second breast cancer, then she can have a lumpectomy again with radiation treatment. With whole breast radiation, which is the 6-week treatment, if a woman is found to have another breast cancer once she's had whole breast radiation, then she will need to have a mastectomy. So at that point, she's obligated to the mastectomy. So it keeps our options open for women later on down the line. At this point, the women that are most likely can we go back 2 slides, that are candidates for partial breast radiation are women that are over the age of 45. If they have DCIS or invasive ductal carcinoma, the cancers are less than 3 centimeters, their lymph nodes are negative, and their margins are negative. And this is just an example of us giving the radiation. So the radiation is essentially in this area, which is where your highest area of recurrence would be. So just to quickly go through mastectomy options for patients, some women opt to have a mastectomy because they're more comfortable with that option versus doing breast-conserving therapy. Sometimes we have no choice but to do a mastectomy given the size of the tumor relative to the woman's breast, or if the tumor is very advanced. A modified radical mastectomy means that all of the breast tissue is removed, the skin is removed, along with the lymph nodes, and the patients will probably need chemotherapy since we do modified radical mastectomies on patients that have positive lymph nodes. They may need radiation treatment and also endocrine therapy. Radiation treatment will only be used for patients that have very, very large tumors or they have a lot of lymph nodes involved. So not all mastectomy patients need radiation. We now can utilize a technique called skin-sparing mastectomies. And skin-sparing mastectomies mean that we're saving the skin of the breast, where we're simply just removing the breast tissue underneath the skin, as well as removing the nipple and the areola complex, because the nipple is breast tissue. This procedure can be done with a sentinel lymph node biopsy, so it is generally better done for women with earlier stage cancers. And sometimes they will also need an axillary node dissection as well, but we always attempt to do a sentinel node biopsy if the lymph nodes are not obviously infected. So essentially the skin is saved, and then the breast tissue is removed, and then we either place tissue or an implant into the behind the skin, and then reconstruct the nipple. So this is a woman that had a skin-sparing mastectomy, and then she had implants, and then had nipple reconstruction. This is a nipple-sparing mastectomy is a newer technique that we've been doing for the last few years, which allows us to save the nipple and the areola and the skin of the breast. So essentially, we're saving the envelope of the breast. We're just taking out the contents, which is the breast tissue. That again, we still have to address the lymph nodes, and then that is done with replaced with an implant or tissue. This is best utilized for patients that are doing this for prophylactic reasons or preventative reasons, and also for patients that have small tumors that are in the periphery of the breast. So this patient is a patient that had a nipple-sparing mastectomy and with an implant, which is the picture on the bottom.